Jason, one of the missing pieces of this puzzle, as PD-1 has moved so firmly to frontline monotherapy or combination therapy, is what's the role of ipilimumab as a second-line therapy for those patients who receive frontline PD-1 antibody?
Well, unfortunately, I think it's a little bit undefined.
Right.
I mean, I think it is, for a BRAF wild-type patient, it's the de facto second-line therapy, but it has really not been well explored what the true efficacy there is. And I think one of the things we just actually didn't mention about CTLA PD-1 combination is what the actual efficacy is. So, I mean, the efficacy actually is quite impressive. Now, your response rate does increase 40% monotherapy to 55% combo, but the question then is, out further, are people doing better? And we can talk about that here in just a second. But in considering the overall picture of toxicity and where to go with this, that's why I present it going throughout the series, because then you can say, here are the trade-offs of each one of these sort of combinations. I don't know, I guess I'll throw it back to you.
Yeah, no, I mean, I think, this, just to build on your point, I mean, progression-free survival, which was the primary endpoint of the randomized phase 3 trial of ipi-nivo versus either of the single agents, clearly superior, slam dunk. I mean, ipilimumab as the per-protocol control arm, no question, but also appeared to be superior with significance over PD-1 monotherapy. And I guess it goes back into this issue about sort of patient selection, for this discussion. In other words, is for response rate in PFS, I think, one has to think about, low disease burden, middle of the road, high disease burden. Like, is there, what's the value proposition of making the scans look prettier, or holding disease and not having to transition from drug number 1 to drug number 2? If overall survival was clearly better than PD-1 monotherapy followed by CTLA-4 as the default second-line therapy, well, that settles that. But I guess, how do you talk to patients about, again, across this kind of disease burden spectrum, about, whether you're favoring or, recommending combo therapy over monotherapy?
Well, I again put it in the context of the toxicity profile. I mean, my personal opinion, which everyone has their own, is that the risk-benefit of monotherapy, I still feel outweighs the combo in most patients. And I think that where the most lies from every individual person is going to be different. I think one of the main things we need to know is what's the benefit in the initially refractory PD-1 patients. What's the benefit to combination?
Absolutely.
In the second relative to monotherapy? And there are a couple of trials that are about to get started to look at that, but that's really the big question, right? Because we'd expect that those patients probably have slightly less than a 10% response, and they're going to do worse because a lot of the best players were already selected out. They would have responded to PD-1. This is where we just don't have the answer, unfortunately.
And the other thing is we are actually changing the paradigm about how we think about metastatic cancer. I mean, it's not, we want a cure, and we want a cure up front. We're not going to go from one treatment to the other and eventually the patient will die at the end of 8 years. That's not what we're aiming for here, and I think in melanoma particularly, we've had this opportunity where it's been a desert for so long to really think about how can we cure up front, which is the attractive thing about ipi-nivo, where you draw this line, most patients, maybe the risk benefit is for anti-PD-1, but if the paradigm is to cure up front and quickly, yes, there's toxicity, but hey, what if they only get 2 or 3 doses and they're done? Like, what a quality of life is that in 6 months' time when they've recovered? Well, and the 2-year survival, now this is phase 2 data, but from the 069, the 2-year survival in the ipi-nivo, all comers, BRAF wild-type and mutant, was up above 60%. It was 63%. I mean, this is pretty incredible stuff.
The interesting thing, though, is related to what we just discussed. The control arm was ipi, where 2-year survival would be 30-some-odd% perhaps.
Or actually, in 2010 when we had nothing, the 2-year survival was 22%.
Yeah, so but today figures somewhere between 20 and 30, but it was actually 55% because many of them, not all of them, many of them crossed over to get either pembro or nivo on expanded access or other trials, or eventually a standard therapy. So the interesting question is, will those curves come together at years 3 and 4? I'm not so sure. I mean, that's essentially a non-forced sequential therapy, because I'm sure there was a fair gap, and actually 40% of the patients never got PD-1 antibody anyway. So you wonder what would have happened had all those patients gotten the PD-1 antibody. Would those curves have come together? It's an interesting question. We'll learn more when we look at the 3 and 4 year data next year.
So I think Georgina's raising this point about, kind of raising the bar further, and I think that is a big motivator of these combination targeted therapy, immunotherapy trials. We don't really have the type of data that informs practice yet, so I mean, I just looking back and forth to see if there's anyone who thinks there's a case to be made for BRAF/MEK plus PD-1 in routine practice outside of a trial.
That's an expensive routine practice, and people are getting away with it. I've heard of this
I want to just make a comment. We have a little bit of data from a couple of phase 1 trials that have reported out initial experiences, and again, in the context of not having robust data, that data doesn't actually look that interesting to me. The response rate looks very similar to targeted therapy, and so then the question is going to be, is it a long-term benefit that's there somehow? But it also looks not that, it looks a little toxic. And so I'm not sure why that would be something. Now, there are caveats to this. We talked about brain met patients that are just very difficult. I can understand how it's very difficult to withdraw the BRAF inhibitor, but I think in a standard clinical approach, it should not be considered standard of care to just overlap everything at this point.
However, having said that, it is all about durability. The whole idea of combining targeted therapy with anti-PD-1 is not about improving that response rate, because as we said before, 95% of patients have tumour reduction. It's all about durability. And the data we have from the dabrafenib, trametinib, pembrolizumab is only 15 patients, not enough, long enough follow-up yet to really make that assessment. But there were some good CRs, and there haven't been a lot of progressors yet in that 15 patients. But it is watch this space. And at this point, I agree with you, absolutely got to be in clinical trials.